So yes, thank you so much for the invitation to speak today. I'll be doing applications of AI in body imaging. So this is meant to be a very quick overview and to give you an idea of what can be done. So my disclosures are that I'm funded with the AUR General Electric Radiology Research Academic Fund, GIRAF. I'm also the Director of Innovation at the University of Maryland Medical Intelligent Imaging Center, also called UMI. Our partners are Amazon, Azure, GCP Cloud Credits, and we have multiple grants, including from the ACR. All right, so very quickly is a survey that was done in the European Society of Radiology, kind of thinking about how AI would impact their reads and their subspecialty. And ironically, for body imaging, there's very few, very few people thought that it would affect urogenital imaging or GI imaging. And oncologic imaging, though, they foresaw a very high impact on their subspecialty compared to the other ones. For example, breast had a very high potential impact compared to the other subspecialties. So just thinking about what that means when we talk about AI, there's a lot of different facets to AI, as I'm sure you've heard throughout this week. And specifically, there's acquisition through reporting and what it means to do image-based computer vision tasks. And we're going to go in this again through the lens of body and abdominal imaging. So for the first part, for pre-processing, right, you can highlight or see better images based on what kind of AI tool you're using to do either low dose contrast, either through the traditional method where you can see it's kind of noisy, versus just low dose AI methods, which kind of gives you similar imaging characteristics, and you can see this liver lesion is pretty consistent across these three images. So when you're evaluating potential tools for your future practice, let's just say you're going to private practice, not necessarily academics, or maybe you're doing academics, and you're thinking, am I going to purchase this tool to make this better? You do have to evaluate and think about what machine am I using, and does it already have these tools? Is it actually going to improve what I'm doing? And just having a study that shows you like this is doable doesn't necessarily tell you if it's actually clinically better. So this is just something to think about as you move forward into your careers. So next, I think what a lot of people are thinking about when thinking of AI applications is how does it perform these tasks to actually diagnose disease, to use deep learning and conventional machine learning to help with computer-aided diagnosis, which a CAD, it's also called, right, that a lot of our breast colleagues have been using for quite a while now, and now can be applied to body imaging and abdominal imaging. So thinking about computer-aided decision support across all the spectrum of risk prediction to disease detection, disease characterization, staging treatment planning, treatment response assessment, prognosis prediction, and recurrence and prediction monitoring. I'm reading this out loud to you because we're going to use these categories to think about abdominal disease and AI. So really quickly, we're going to jump, actually, we're skipping over risk prediction. We're going to come back to that at the end. We're going to do disease detection and disease characterization first. So there is a radiographics article you can check out. There's going to be citations at the end of each of these slides, so you can go back and read more. But really quickly, for deep learning, you can do different tasks and ask basically the AI tool to do different things. So one is image classification, where you classify whether or not a disease is present. The object detection, where you actually narrow down, do bounding boxes, heat maps on exactly certain features of that image. You can do segmentation and instant segmentation, two different types of segmentation where you actually draw out that border. And you can do all sorts of things across these types of different computer vision tasks. So be very thoughtful when you're reviewing papers, looking at tools that you know exactly what it's doing across these things. So you can imagine that for liver mets, whether or not they're present or not, versus detecting specifically the mets versus the aorta versus your spleen, versus segmenting out, yes, you need the contour of that liver met, versus segmenting out the different mets in that liver. So here, another task for classifying and then also detecting, right, these different organs in an ultrasound. This is just here to highlight not necessarily the classification or detection, but actually highlighting some challenges with ultrasound. As you can see, compared to just a 2D image, still image, ultrasound introduces different characteristics that need to be considered, including the fact that there's burned in data that needs to be de-identified in a different way. There's also the fact that it's operator dependent, and as you all know, and the images that are acquired are not necessarily standard on every scanner, nor every person that's performing the scan, and that there's consistently artifacts that need to be accounted for. So there's a lot of papers now trying to understand how do we do ultrasound AI because it presents unique challenges. So another thing is on CT, there's a new tool that people should be aware of. It's called Total Segmentator, really great tool that has correctly identified over 104 anatomic structures on CT images. And you can see that this was recently published July 5th, 2023, hot off the press, right? Radiology Artificial Intelligence. And you can see all the different things it's able to segment, and you can think about all the different tools and applications you can potentially do with this new tool. And also just wanted you to be aware of, this is actually, it's now 8 days. I took the screenshot last night. So there is RSNA 2023's abdominal trauma detection. If you're interested in AI, you wanted to try out some of the tools that you've been learning about, you can participate in this challenge with the RSNA. I think it's a $50,000 award. And since this is in the abdominal category, I wanted everyone to be aware and think about doing this. Yeah, oh, right here, $50,000, correct. All right. So then also thinking about this, this was a paper that came out in diagnostics, and it categorizes all the different things in the GI section specifically across these different diseases, how gastroenterologists also consider thinking about AI, because especially in radiology, we need to also think about what our referrers will be seeing after we do these reports. And it's interesting to me actually that there's a lot of AI applications now that gastroenterologists are thinking about, and especially as they do endoscopy, there's robotics involved with artificial intelligence tools, and also risk analysis as they kind of predict in advance patients that need to be followed or screened for different reasons. So, for example, you'll see this non-alcoholic fatty liver disease, which is rising as a cause of cirrhosis. And you'll see that there's also here, right, by endoscopy, there's a lot of endoscopy interest. So all these different diseases that our GI colleagues are thinking about, that I wanted to give that perspective so that we're also aware as we progress through our careers. And they do severity scoring, prognosis prediction, et cetera, et cetera. And so this is just a highlight, right? The AI is not just in radiology where you can detect a lesion, is also in endoscopy, and thinking about correlating even across modalities, not just in radiology, but outside of radiology. So again, highlighting the endoscopy aspect of this, as we develop more tools, there's now more interest in doing multimodality correlation. And so this is a potential area to be involved in as well. And I also want to highlight here that endoscopy is not just in the GI section, but also in pelvic imaging and bladder imaging. And so cystoscopy is one of those areas, right, where we usually say, hey, we can't detect this bladder cancer, but what if you could? And thinking about that. Also in the urinary system, thinking about kidney stone segmentation, there are tools available to do that kidney stone detection. Okay, so one other thing I just wanted to highlight, since we're discussing AI, I'm sure you've heard of this already throughout the week, but thinking about where data sets are not just obtained, but also where AI tools are applied. And this is, as you can see, across different countries. This is a really interesting study that was done to think about a fetal ultrasound tool that was developed and seeing how it performed in different countries. And this is just something moving forward as we're thinking about tools and how AI is applied, and fairness and bias and generalizability of tools, thinking about that across different tools that you're going to be evaluating. I know this is specifically for fetal ultrasound, but this could be applied anywhere. So thinking about that as part of our discussion. So now that we've thought a little bit about disease detection, multimodality stuff, disease characterization, also thinking about staging, treatment planning, and treatment response assessment is also going to be interesting, because there's a tool. I'm not advocating for any particular tool. This is just an example. There's AI metrics that's available for oncology. And as we had thought about earlier, oncology is very interesting to our colleagues in oncology, and then also in radiology, as we have to measure all these lesions, right? So there's automated measurements, and they can just kind of click through the way you've seen in breast imaging, for example, click through these things, they can track lesions for you. And then interestingly is thinking about reporting, right? Having this defined for us and kind of automated measurements is really great. And then having a different report that is better than listing out 1,000 lesions and then having to dictate all of that. I think this automation is really key. That saves part of our workflow and also is more accurate, and also both for our dictation and also for our colleagues that are reading our reports, that they're able to see something so simple in a way, right? And you having a partial response summary is really fantastic. And also the percent change from baseline, et cetera, that's automated. So next is prognosis prediction. I think that's another really interesting thing. So we're moving away from just saying, hey, define whether or not this exists, or measure these lesions for me and see how if it's responded, but thinking forward for the patient, how well are they going to do? And this is interesting because there's been a lot of research, I think, again, from non-radiologists, but also in radiology to think about, are they going to survive? And there's been quite a lot of studies, and this is just one paper in Health Data Science, based mostly in gastrointestinal diseases, that you can see that there's been 21 studies on esophageal cancers, 93 in HCC, 54 in colorectal cancer, and 36 in gastric. And this was just published in 2023, so you can imagine these numbers are going to go up. And it's just, there's a lot of tools thinking about that aspect. And I do think as we do, again, multimodality studies, so not just looking at the images, but looking at the epic information, looking at where patients are situated, and kind of epigenomic studies, that we're going to see more of this ability to give more accurate prognoses to patients. So then we're moving into this last category, and this is something to think about carefully, is thinking about risk prediction and also recurrence prediction and monitoring. And so this is another fascinating aspect of incorporating multimodality imaging. We'll think about this a little further. So let's just jump into this study. So a lot of patients, right, they'll receive multiple radiology assessments during their care. They're going to, this is an overview of how to do this. So during that period of time when they're uploading all these images, you're going to have to scan and report all these things from a PACS system. The patient identifies a retrospective cohort for AI studies, right? Then the DICOM imaging data is curated and annotated. Oncologists compile a database of outcome information. This is your multimodality piece. And then the imaging and clinical data are anonymized and securely transferred for AI research. So this approach incorporates radiomics, which takes all these features and they select it out for an ML model. And they also then train based on all the things that we've just described up in this workflow. And given that training, they can do outcome prediction, where they look at the response or the benefit from therapies, adverse events, and the confounders. They also look at the prognosis and whether or not they need to escalate or de-escalate therapy, and basically the overall survival and the disease-free survival, et cetera. And also the radiogenomics and kind of identifying those molecular characteristics and the radiomic characteristics of how a disease might respond. And I think this gets into the aspects of things that we didn't necessarily think about or weren't able to think about from the abdominal imaging side, right? We want to get down to evidence-based, molecular-based imaging and being really able to provide that extra level of care. And AI allows us to compile large data sets to consider what we can learn from that data, aside from just saying, hey, we think we can do this and it's possible, right? Like we can actually do it now. And I think this has been best done, I think, in neuroradiology with GBM data sets. They were better able to characterize subsets of disease based on image features and been able to characterize that off of the image. So that'd be really cool to do more of in abdominal imaging moving forward. So this, for example, in prostate cancer, this is a study that was done in prostate cancer disease, and you can see that they've done this specifically for prostate, and it basically takes all these steps. I'm not going to read them out loud to you, but you can see that if you're able to get pathology results and incorporate that with your imaging, you can then generate better risk stratification and clinical action for that patient. And thinking back now, so that was prognosis and thinking forward, right? Now thinking backwards in time, there's a lot. This is a study done by Perry Pickard over at University of Wisconsin. This was published in Lancet Digital Health. This is a really fascinating study. I'm sure all of you have heard of at some point of opportunistic screening. So this is a huge area of potential gains for the patient. I think a lot of us, when we get a study, we're evaluating them for HEC, we're looking at them in that one period of time, right? And we're only giving back the information that we're aware of. And if we're not aware of things like, for example, visceral fats and correlating that to disease outcome, or muscle density and sarcopenia with somebody who might be frail or older, mean volumetric liver density, which does steatosis evaluation, rather than just saying your 40 Hounsfield units difference, or whether or not this was a contrast study. Aortic calcification score, right, a Gadsden scoring, and also vertebrotrabecular densities, osteoporosis, etc. Having this kind of spectrum of evaluation on things that you would have noted and buried in your findings somewhere, thinking of the patient as a whole and thinking of their disease state or pre-disease state gives you the ability to do a different type of screening, opportunistic screening, right? That would then inform how that patient may prevent disease. And I think that's really critical moving forward. So having So what their study did was they did longitudinal follow-up for adverse clinical outcomes based on all these features of those images. And you can see that this CT scan, right, of a person across this time, they found the visceral to subcutaneous fat, found the liver density of the 97th percentile, and their aortic calcification. And then 12 years after the original study, right, the disease, the progression of the calcifications at least was much more severe. They were able to predict, right, build a model to predict that kind of outcome. And I think that's going to be really exciting moving forward. So one thing is you're probably thinking to yourself is, that's all cool and that's super exciting, all these potential tools, but how many of them are usable and in practice now? And you can see that the FDA approvals for AI-based devices in medicine, right, has really increased a lot over the years. So this is just an overview of all types of tools across all domains of medicine, and radiology is a huge chunk of that. We actually have the majority, I want to say around 60 to 70% of FDA cleared AI tools. And you can see based on this diagram also that that is disproportionately large compared to everyone else. That is a combination of both the fact that radiology is much better about standardizing our imaging and our tools. So it's been a really great period of time for radiology to develop these tools. And so this was a paper actually by Dr. Pertrick, who has been coordinating this educational session. So you can go ahead and look at this paper, which I think is also really great for body imaging. As soon as I saw this paper, I realized that I should have just said, hey, you should have given this lecture. But there's 300, at the time that they published this paper back in 2023, April, there were 343 applications, it's more now, and they found 101 body imaging specific applications. Some of them are which are in the chest, and but because they were valued all of body and not just one particular organ. But there's 101 body imaging things, so 91 total applications were assessed in their paper, and they kind of did this really great diagram of which tools were in which were applied to specific organs versus multi-specialty. And one last category I want people to be aware of as we move forward. I know this has been on everyone's minds is ChatGPT and LLMs. So I wanted to just highlight this one study that was done by a group at Stanford that was thinking about the accuracy information provided by ChatGPT and how patients interact with that large language model. So one of the things that patients might do when they interact with LLMs is ask it medical questions, right? Just about screening, about disease states, about organs, etc. So they kind of assess based off these 20 questions, things like what is liver cancer, how to prevent liver cancer, right? Or my liver MRI report says I have a liver, 1 lesion, etc. And then asked it to give a score on how reliable that answer was. And you'll see, interestingly, that it does pretty well with generic questions. So what is liver cancer? They did pretty well. Is, am I at risk for liver cancer? Also did pretty well. But it didn't do that well with more specific medically applied questions. And so I will say that this is actually, and I want people just to be thinking about this. This study is interesting, but I also want to say that like ChatGPT is evolving on its own. There's a lot of, and ChatGPT 3.5 versus 4 is also a whole different story. And also that it is not the only LLM out there. And so I think as people have more choices, it's almost like saying back in the day when you had Google or Yahoo or whatever else, right, to do searches, that they perform differently. And I would say LLMs also perform differently. And again, LLMs have a challenge with what it's learned on. And so if it has very generic data across the world, it may not have very domain specific, medical specific knowledge. That's one category. And another thing is it doesn't necessarily have the data that you have access to. For example, the EPIC information, or when you were reading that report, you were probably looking at the patient's risk factors, et cetera, that the patient may not know that it needs to give that information to the LLM to do that. Or if they do, that's also a risk of sharing things beyond like when it's uploaded, that's a patient privacy issue, confidentiality issue that they may not be aware of, and it might be out in the world again. So I think there's a lot of factors to think about as people interact with this more. How do they use it, and how does that affect their health outcomes, and how does that impact how they interact with radiologists? Because if they put this in and we know it's unreliable, they may not, and they may get a really weird answer. So I anticipate that this is going to change how body imaging and AI, as LMs are a piece of AI, will be different in the future. So I just wanted to highlight, this is our group, and we've been studying now a lot more recently, both AI and the subset of LLMs. So consider looking at our website and coming to think and reading some of our papers and thinking about not just development imaging, but all of AI in general. So thank you for listening. And if you have any questions or comments, feel free to reach out to me, and this is my email.